Okay, good afternoon, everybody. I would like to first thank all of you for joining us for the VUSN COVID Leadership Panel. And I would ask if you have any questions, please put them in the chat box and we will address those questions if time permits during this session and or after the session. You will receive an email from Betsy and or Sarah from the prospective panelists that you have sent your question to in order to address your question. So we're going to just jump right in. So we're going to start with April. Dr. Kapoor. So for years, medical centers have been practicing mass casualty events. Can you just share with us how Vanderbilt University Medical Center, as well, Vanderbilt University and the medical center prepared for the pandemic?
Yes, I can speak to the medical center side. So yes, we have an emergency operations protocol, a manual. We've got an amazing emergency medicine, emergency operations team. We've had several emergencies throughout the years, so that's given us plenty of opportunity to practice. Interestingly, in March of 2020, our command center was open at the beginning of March because we had experienced a massive tornado here in Nashville and Mount Juliet. And we were dealing with the issues surrounding that tornado. We were getting ready to wrap that up, and then COVID came to Tennessee. And so we kept our command center open and changed it to the COVID command center. Our incident commander was Chad Fitzgerald. And if we had not had that foundation, the emergency operations protocols and procedures in place, we would not have had a good foundation to build from there. We are still open over 400 days later, and we've learned a lot throughout the pandemic, a lot of nuances that you have to address. You can't get everybody in the room together. You can't do a lot of different things that you would normally do, but those nuances we learned and we innovated and we put things into place. And so going back to your question, yes, having that foundation was very important.
Thank you. I'm sure you've got a lot of lessons learned. So God forbid, if it happens again, you'll be able to go back to your playbook and roll those things out. Dr. Wargas, you and I share something in common. We're both retired Army Nurse Corps officers. And can you just share with us how your Army training, your Army Nurse Corps training, helped prepare you for your role at Penn State as a COVID Commander-in-Chief?
Yeah, thanks, Gwen. Great question. I think it's a combination really of my nursing education that we all share, as well as my military experience. Nursing, of course, we have the nursing process. It gives you a great foundation, bedrock for decision making. And that is very strongly enforced and endorsed in the military as well. Military is a leadership, the emphasis on leadership, decision making, being able to take all the information as much as possible at the time to make decisions quickly, swiftly, and through a process and not just a hunch, right? Using the facts and the assumptions and making good sound decisions and using the evidence that is out there. And so I think that's a natural complement between nursing, my nursing background and my military background. And I'm grateful that I was able to serve at this time for Penn State in a very historic time for the university.
And I'm sure Penn State has benefited from your wealth of knowledge. It's like it's something you can't turn on and off. You're just a soldier forever.
Indeed.
Indeed. So Dr. George, you're an engineer. So can you share with us what your experiences were as an engineer working with Dr. Dean Normus, as well as Dr. Pam Jones, who are nurses? I'm interested to hear how, as an engineer, you were able to understand nursing lingo and nursing way of life.
Well, that's a very good question. You know, I really had not had much experience prior to the pandemic with nurses, you know, other than personal experience in a hospital or a doctor's office. And it has been a remarkable journey. I co-lead the Vanderbilt Incident Command Center with Senior Associate Dean Pam Jones, and has also worked hand in hand with Dean Norman as she has led the Public Health Advisory Task Force. And I have to say, it just, has opened my eyes to to nurses and what they bring to the table. I mean, our School of Nursing, they stepped up and they stepped out and they stepped in front of everybody and have led the university's response to the pandemic in such an amazing and capable and caring way. And that unique and unexpected collaboration I'm an engineer, I'm a safety professional, a sustainability professional, I think has really been very powerful for the university because, you know, Pam likes to say she brings her clinical brain to the table and her people, you know, her people skills, and that I bring to the table the organization and the process and kind of the systems thinking to the table, and putting all of those things together have allowed the university to invite all of our students back to campus for the entire year. And we're the only top 25 university that's been able to do that and remain open the entire year and never, you know, never go to online. And I've told everybody that would listen, if I ever go to war again, because I really look at this past year as a war against COVID that I've been in for 412 days as of today, I count every day. I want a nurse next to me in that foxhole, because the can-do attitude, the grit, the persistence, the work ethic, and, you know, just the selflessness has been remarkable to really get acquainted with and see and watch. And I just have been so thankful for this experience.
And you know, you bring up an interesting point. In my role as a surveyor, we have, of course, engineers on the team. And you're right, all of the different perspectives and understanding about healthcare and how the engine works. You need that other different viewpoint in order to make it work well. So thank you for adding that piece of information and being a valued member to that team. I'm gonna kind of digress a little bit to Dr. Randy Rosh. So Michigan has been on the news, well, like other states, but probably more so than most, regarding your leadership, the statewide unrest during the pandemic, the surges. Can you just share for us, in the early days of the pandemic, how did your Governor Gretchen Whitmer, when she reached out to you, what were her primary concerns, and what was her number one objective for you as you prepared to move your state along in the COVID pandemic?
I was honored to be asked by Governor Whitmer to serve on the Coronavirus Racial Disparities Task Force, and that task force is led by the Lieutenant Governor. I'd say that Governor Whitmer has been very forward thinking. One of the things she did was recognize that we didn't have data on minorities in terms of testing, all of those, the risk, all of those kinds of things. So one of the things she put in place was to start gathering data, and I believe Michigan has led states in gathering those data. Other governors have followed through with that. But I think the primary concern that we got right away was that minorities, especially in marginalized communities, were at a much higher risk for infection, mostly because of the roles that they perform in society. They were on the front lines of workers, so they were exposed in all kinds of ways. And there were higher, in that particular population, higher instances of chronic disease that also put them at risk. And one of the problems we were facing was we didn't know not just the exposure, but the actual infection rates and getting testing. And so all of the testing that was in Michigan and in most states was drive-through testing. But there were certain communities where they don't have their own vehicles. So to get to testing, they didn't take taxi cabs, they took a bus. And those buses, taking the bus and there's a lot of time that you just spent waiting to get on the bus and all of that. And when you got to the testing site, you couldn't be tested because you had to have driven up. So the coronavirus looked at a number of things that we were doing. We had two task forces originally. I chaired the Primary Care Connections Task Force, and there was a task force on testing. So one of the first things we did was to take the testing to the people.
Mm.
So take the testing so people could get tested in their neighborhood, in their church community center, just in the neighborhood. So we did that. And at the same time, we started collecting information about them in terms of, did they have providers? Did they have insurance and all of that? So we use this to leverage other issues to try to address the broader health issues. You could say the social determinants of health. The task force has even evolved now to begin to look at things like housing, food, all of those kinds of things. But the things that we learned that you wouldn't really, that probably people wouldn't have thought of was there were also higher risks because people couldn't conform to the CDC guidelines for social distancing because of who lived in the households. Right? There was no way to social distance in a household and people were coming and going. And we also begin to look at those members of the population who are they're not technically homeless, but they're homeless.
Right.
So they're living on sofas out of the goodness of family members and neighbors. And so they would go from home to home. And so they would expose people because they were coming and going in those ways. And I will just add that the other piece that we learned from is our large universities. So Michigan State University has over 60,000 students. And when it went virtual, a lot of these students went home. So our students who came from marginalized communities and underrepresented minorities were afraid when they went home that they would expose their family members to the virus. So we're still learning a lot of things, but those are some of the main things. And the governor has been really a leader in putting this task force together. It's been recognized nationally. We just won a national award for the task force, and President Biden just asked Dr. Janae Caldoun, who's our medical director for Michigan Department of Health and Human Services, the work that she's done with the task force to leverage some of this work nationally. So we've had quite an impact, and the governor was really at the forefront of putting this together.
Well, thank you for sharing your beginning. There are some follow-on questions that we'll get to that will dig a little deeper, but thank you for giving us the tip of the iceberg. So Dr. Ken Nelson, can you share with us, tell us about how St. Mary and St. Vincent was able to partner with communities, organizations in the very beginning of the pandemic in order to help you guys lead the way in the COVID pandemic?
Oh, thank you. So for those of you that aren't aware, Green Bay is a pretty small town, relatively speaking, even though we do have an NFL team. But healthcare in this city is very, very competitive. There are 3 different health systems in a city of just over 100,000. In fact, one of the hospitals is attached to my building. We share a common wall on the north side, which is also very interesting. So up until the pandemic started, like I said, we were very competitive. We are a trauma center, level 2 trauma center, comprehensive stroke. So our catchment area goes up into the Upper Peninsula of Michigan, as well as most of Northeast Wisconsin. As we got deeper into COVID, though, we realized that all of our organizations came to the realization that we had to really set aside, we were all in the same boat. We had to set aside a lot of our competitive nature. A lot of the elective things were shutting down anyway, and we had to put community first. So I was fortunate to have, either drawn the long or short straw, depending upon how you look at it. But one of my primary roles at the beginning was to coordinate with the chief nursing officers, not just in Green Bay, but in some of the surrounding communities, to figure out what we were going to do if we got hit really hard. How would we manage where patients are going? What would we do about equipment, staff, et cetera? There are a lot of rural communities just outside of Green Bay. So we were able to work together and come up with sort of it was more of an incident command that really spanned multiple organizations. And in doing so, we were able to work with our legal teams as well. And we had memoranda of understanding for us to be able to share equipment, to be able to share supplies, and to be able to share people across the organizations without, we all recognized each other's vetting process and everything like that. And so it worked out quite well. We had, of course, daily operations meetings among the entire community every morning, 7 a.m. sharp. We were all on. And as time went on, we also found other opportunities for us to leverage and share resources. Now that things have quieted down a little bit, I'll admit a lot of the competitive spirit has come back. But we did learn that we are better together than we are apart, and that was probably the coolest thing that happened during all of this.
I appreciate you saying that, now the competitive spirit, because that's also a sign that things may be getting back to normal. And did you say, give me back my nurses if you had some over on the other side?
Right, and give us a few extra too for good measure.
Exactly. All right, Dr. Wogath, so can you share with us, if I'm not mistaken, Penn State has 24 campuses?
Mm-hmm.
Can you, we used to say corral the herd or get everybody on that bus. Can you share with us how you were able to do that with 24 campuses as it relates to getting folks, adhering to the I don't want to say the standard, but compliant with the rules and CDC guidelines?
Yes, thank you. Yeah, Penn State's a big organization, 24 campuses. We have nearly 100,000 students, 17,000 full-time employees, and many, many thousands more part-time employees or different categories of employees. And we're geographically distributed across the Commonwealth and actually outside of the Commonwealth and other states in the United States. So it was a big deal. And I would say there's 4 things that helped me do that. The first one is position power. The Board of Trustees, the president, the provost elevated this position to an executive level position. So I meet with those constituents, the president, the provost, routinely, right? It's at that level of the organization. That's very helpful. The second was I had decision-making authority. So I was granted that authority to make decisions on things without having to always go through the permission, the pipeline for permission for everything. Didn't need to do that. I could make those decisions, obviously with consultation and advice. And, we had a lot of expertise and input to that. So they're not singly my decisions. However, I can make those decisions without a long delay in those decisions. The third thing was resourcing. I had resource approval as well at a very high level. And so I could move money around to resource whatever I need, whether it was manpower, testing, whatever resources we needed at whatever campus, I could move that money around, again, fairly easily, which was wonderful. And the fourth thing that I think we probably all would nod in agreement is communication, communication, communication. Setting up the structures, the meeting structure, the update structures, the written messages, the social media messages, the community messages, the parent messages, the student messages, the employee and faculty and staff messages, the political messages, right, to our state and our Department of Health and all the other constituents that you have when you're a huge part of a state of the Commonwealth of Pennsylvania. I mean, Penn State is a very prominent part of the state. And so there's a lot of folks that have concerns. And frankly, staying very open and transparent. My email got out very quickly. I would get either phone calls or emails from concerned parents, concerned community, whoever it was. But I made it a point to answer every single one of them. Now, we had a call center and we had an official way for people to tell us their opinions. But if it got to my email, I wanted to answer. And I also spent a lot of time talking to people on the phone because, there's no better way to help a parent understand what you're doing with their son or daughter than to talk to them on the phone. I'm going to go back to my nursing education and my nursing upbringing and the people skills that Andrea just talked about, right? I mean, those people skills really help. So while it wasn't perfect every single day of all of this, without a doubt, and I'm not patting me on the back, but we were able to have students on the campuses since this all began for us officially last fall and into the spring now. We were on a remote, the original spring back in 2020, but since then we've had students on campuses across the Commonwealth and our employees. So I'm proud of that. So those 4 pillars were really, really important.
And what you all have demonstrated that it can be done. I know there were some schools that shut down and wouldn't allow students to come back, but I think as an example, well, having Vanderbilt DNA, it does help to demonstrate that you have that drive, as well as you, Dr. Kapoor, that you guys can do it if you have the right people in place. And
Yes.
speaking of the right people in place, Dr. George, can you, from an engineer, and again, I'm not hating engineers because I love my engineer. Every time I
Well,
walk,
it's not.
I don't move anywhere unless my engineer is beside me. So with that said, how did you staff the command center? Can you just give me your thought process, briefly about how you staffed the command center?
Yeah, we took a very unusual route. Typically the command center would be staffed by, trained and
Right.
people who are with incident command training, maybe police department, et cetera. Because of the way we wanted to handle our contact tracing and our interaction with positive and quarantined individuals, we sort of moved that into a two-pronged approach, one that was clinical based with our School of Nursing. And so all of our contact tracing and all of the follow-up, we actually talked to every single positive person or quarantined person every single day that they're in quarantine or isolation. All of that has been handled under Dr. Jones and with School of Nursing staff members, mainly faculty out of the School of Nursing, actually have volunteered to do most of that. And then we paired the clinical side with administrative staff that I've led. And those administrative staff have been very interesting. We basically sent out a call for anyone who had capacity that could help us, that had organizational skills and data management skills. And we ended up staffing, we have a virtual command center. It's not a location. We all have worked virtually all year with each other. And it's been staffed actually with folks who were greatly impacted by the student activities and study abroad professionals. Student volunteer professionals, people who have had no emergency training and no real skills in this area, but they came together and it was really all about mission. We stayed focused, laser focused on mission, that this is the best use of our time, no matter our background or skills. This is how we can help the university right now best. And we talked about mission every single day. And in doing so, we were able to really clear away, the things we didn't need to focus on how to pull together processes, testing management, data management, communication. Our group does all of the communication with everyone, reports up to management. And we've done all of that by asking that group of all of these varied individuals for input and their thoughts about how best to do it, and really, continuing to stay always focused on that mission. And it's been amazing that everyone has risen to the challenge. Everyone has bonded together. I have never met many of these people in real life, but have led them all year. And we have worked 20 and 24 hours a day for 412 days straight, and without really a lot of angst or cross words, because everybody has a voice and they know that voice will be listened to, and they bring a valuable skill set to the table no matter what their background is. So I encourage everybody to think a little outside of the box sometimes, and think about unique and collaborative partnerships that can come together and really form something very powerful.
When you mentioned the focus on the mission, you just be surprised at how much you can get done when the common goal is the goal, or the patient, putting them in the center, remaining COVID-free in the center. Too bad we can't carry that same philosophy like on a 12-hour shift. I remember some that you were low crawling to get off. Like, just please get me to the car. But I do appreciate that you spoke about how collaboration can, has perfect outcomes if everybody just share the same common goal. All right, so Dr. Nelson, can you share with us what is the hardest thing that you experienced as a CNO during the COVID pandemic?
Boy, I thought a lot about this question. And
how did you know the question?
It's well, lot of reflection even just over this last year. And I think, you know, there a lot of operational things were maybe difficult, you know, opening up new units where there were no units before, you know, and creating ICUs out of empty space, having to manage between both hospitals and trying to, you know, make sure that we were staffed appropriately at both places, you know, that if one hospital was getting hit hard, that we had good mechanisms in place to move. But to me, I think the hardest thing has been, for, you know, for a while, not having a real end in sight and having to continually lean on my teams to ask their nurses to just, you know, to stay one more extra shift, or to, you know, come in on their day off again, or to, you know, have to, you know, ask them to just at all hours of the day, just be ready to go and present. That it's tough because it's not that they would ever say no. It's
Right.
just tough to have to ask of people when you know that they're already at their maximum. And I think that the mission is a theme. I think that Dr. George really, it hits home here too. You know, everyone did it for, you know, our mission at the time, as always, is to care for this community. And so that may have made it easier, but it's one of those things that, yeah, I wish I wouldn't have had to have done, but you know, that's the way it works.
Right. And when you talk about the community, I'm going to kind of digress just a little bit to Dr. Randy Rosh in terms of the marginalized community. And we've heard of healthcare disparities, socioeconomic challenges in those same communities. Is it anything new that you learned about disparities in those communities that has not been, you know, no one's ever talked about? Did COVID manifest anything new that we didn't already know about healthcare disparities?
So I think the details of healthcare disparities maybe emerge. So the things that we know, we learn details about them. So for instance, I think, you know, off the top of your head, you wouldn't think about what the CDC guidelines that were issued, and then how do you deal with folks who are living in situations that most of us don't live in? So crowding, all those kinds of things, traffic, even getting masked. So the social distancing, all of those pieces, what we learned from talking to communities were those pieces. And I should be clear that the coronavirus task force is an official task force, but every Friday there's a meeting with community leaders, a variety of community leaders who would meet with us from across the state. So we learned a lot from different communities that we wouldn't have known before. And so the details are pretty amazing. I could say that one of the things is if you go to michigan.gov coronavirus task force, a lot of that is posted. You can actually hear our meetings because they're recorded and made available to the public. So I would say it was those details. Some of them we know broadly,
Right.
but what emerged was the patterns and the details that this pandemic has exposed.
Yeah. And that was one of the questions that I remember asking earlier on when they were talking about health disparities and marginalized communities not having access to masks or just not getting tested. And we'll talk about vaccination later, but you know, how were they going to be able to go get the mask, or how were they going to be able to not social distance when they have to ride the bus to work? So certain things that we, you know, are privileged to be able to do, like drive to work. We know a lot of people were not able to do that. So those things were already known, but were magnified during the pandemic. Dr. April Kapoor, can you share with us what was your greatest challenge overseeing the clinical and non-clinical labor pool at a busy regional medical center?
I think every day I learned and was constantly challenged. In our command center, everyone had a specific role. And so we had you know, someone in charge of supply chain, and all she did all day long was contact people across the globe to make sure we could get as much PPE as we needed to protect our healthcare workers. We had our infectious disease team, world-class physicians and nurses on that team constantly monitoring the situation and coming up with guidelines. We had our communications team communicating with the media, communicating internally. We had our patient experience team constantly looking at everything from the patient's perspective. And so my role was the labor pool. And my day job, my usual job is I am over advanced practice. It's not being over the labor pool. So it was all very new. You know, I knew about the labor pool because usually when we have emergencies, we're open for 3 to 5 days and then we close down. We shift labor at a very small scale. In this case, we're talking about 20,000 employees. And at the beginning of the pandemic, much of our volume and all of the patients were going to our ambulatory sites. So we were putting up pop-up clinics. We had a huge volume to our walk-in clinics, our primary care, because everyone is trying to go in and be tested. And so we had to look at our labor across the system, both the clinical and non-clinical, and essentially categorize every single employee. So if you work in the research department, what else can you do? And so everyone was assessed for their skill set. If you're clinical and you're a nurse and you work in the ICU, can we move you potentially to other ICUs? So we had to categorize every single person. So it was a huge database. We had the smartest person that could manage our labor tracking system. And so everybody was categorized. They were the CV19 this or the CV19 that. And then the next thing we had to do is really look at what was happening with our labor. So we were seeing lots of employees go out because they had COVID or family members had COVID and they were going to be out for quite a while. How do we backfill them? We had a lot of employees that could not, they were very high risk, could not even risk being exposed to COVID. And so they had to be moved home. Well, what can you do from home? So we had our whole category of at-home work. Let's call this group and ask them who can start to do this work. So hotline work, things like that. So we had to look at what was happening with the shifts. So it started with ambulatory and then slowly it came to inpatient and just hit inpatient. We had a surge in the fall. Then we had a huge surge in January of this year. And we had opened up 3 additional floors of ICUs. And so when you ask what the biggest challenge was, I would say nurses. Wow. So when we headed into the pandemic, we were already short several hundred nurses. So we were already working with travelers. We were already heavily recruiting to the community before we even hit the pandemic. And so now we're having all of these shortages. And so how do we bring in nurses? So, so this is where, you know, the learnings were every day. And one of the things I learned is, as we all know, communications and relationships are everything. So we knew we had to reach out to the community and try to get as many nurses as possible to come and get on board. We had to figure out how to train them in an expedited way, make sure we checked all the boxes in terms of training and onboarding and safety management. So how did we get as many nurses as possible? Well, certainly we reached out to travelers, brought in a lot of travelers from our travel company, but we did something interesting. It was a Friday afternoon. In our command center, in our labor pool command center, but by this time we had moved to our own command center. I had the fortune of having our executive chief nursing officer literally in the same room with me for the past several hundred days. And she knew so many people in the state of Tennessee. She knew the deans, she knew the healthcare CNOs. And so on a Friday afternoon, we drafted a letter for her to send out to every one of the deans, all of the CNOs, and say, you know, we're looking for nurses. And we had a link. And by Sunday, I had amassed at least 100 nursing managers to interview all these people that were saying, we're interested, we'll come help, we'll do whatever is needed. And so we interviewed just literally thousands of nurses over that weekend. And by Monday, we had just shy of 500 nurses that we were going to bring in anywhere from PRN just
Wow.
8 hours a week, all the way to 24. And we started figuring out how we're going to get them in, train them, and deploy them, really understand their skill set and where they can go. So that was just a huge outpouring of support from the community, but took a lot of just on the spot innovating and figuring out how we can get people in as soon as possible. So that's been the theme throughout for me, was relationships, always reaching out to those people you know. And so the biggest challenge, to answer your question again, was really nurses. Really in need of nurses.
And now you can breathe a little.
And now we can breathe a little bit. Yeah.
I said a little because you never know what happens, what could happen next week. But thank you for sharing your story. Andrea, Dr. George, can you tell us a little bit about why you focused on research first, or personally?
Yeah. So, if you think about research, they are unique population who were already the most used on the people on campus who are the most used to following safety protocols and safety requirements. They're already trained on how to don and doff PPE. Their buildings that they work in, research buildings, are uniquely constructed to be safe and handle infectious agents already. They have the highest levels of filtration and ventilation that you can have in a building. So
Right.
their environment was the most safe on campus. Their skills were already there that they could kind of, transition easily to work safely in this environment.
Right.
Most laboratories are not really dense and heavily, have lots of people per square foot, so they could, with some innovative and unique thinking around scheduling, could de-densify quite a bit, and their work does not translate to home. They cannot set up an infectious disease lab in their dining room. Like, I could set up my computer in my dining, or at least we hope they didn't. Let's just say that. And so,
all over the
right. So it was very important to get them back up and running. Many of them were clamoring to come back to campus to continue their life's work, and they were starting to lose it. When it's sitting, a laboratory is not meant to be idle. And so things were dying, and their grant funders didn't necessarily excuse that they were at home with COVID. And so they were losing money. Their experiments were having trouble. Their animals were, all of these things. So we really focused there, thinking if we can bring research back safely, then we can learn those lessons with them. And they're experimental, so they didn't mind that we were kind of experimenting on them a little bit. We can learn those lessons there with them, and that can translate and inform what we need to do for the fall to bring the students and the other faculty back safely. And, we were really successful. We ended up not having this whole year a laboratory transmission of COVID. Now, we had some transmission of COVID, but it was more people who were roommates, or they had all gone out to dinner together when they weren't supposed to, that kind of thing. But we didn't have transmission within the laboratories. We also created a really strict protocol system that they had to basically apply to come back. And so they had to create an application. We said, we want you to talk about your scheduling, your distancing, your experiments, who needs to be there. But it was up to the researcher to tell us how they were going to act safely in their laboratory. And then there was a very informed group that evaluated all of those and approved every person that was coming back, every lab that was reopened. So it was a very successful endeavor, but that's really why we focused there first, was they were uniquely suited and we could learn lessons there.
Now, this next question is for all of you. Just briefly, if you can share, because we leaders take care of their employees, their staff, soldiers, those that work for them. Can you just share with the group, and for those that are listening, how did you take care of yourself? What were some of the things you did in order to we call it, I'm on stage. I look good, but I might be deep down inside, I'm tired. But can you just share what were some of the things you did so other leaders don't feel like that, you know, it's okay to say, I need someone to talk to. It's okay to say I need a break. So can you share, and let's start with Dr. Rush, and then we'll go that way. So can you share just some of the things that you did in order to keep yourself up and coming?
Yeah, thank you. I think the first thing I called was the 3 M's: murder, meditation, music. And by murder, I talk about murder mysteries, the kind that are
Okay.
comic. They keep you engaged, but they're humorous, so they keep your mood lifted. Meditation, which is something I've practiced for a long time, and a variety of meditation, so not just sitting meditation, but walking and being at one with nature when you go out on walks, so that gets exercise in it as well. And then music, which I think, I'm a singer and a musician, and it uplifts me. So I would pick certain pieces that I listened to over and over, and you would be surprised. Some of them are spiritual in a way that you would think of it, but I also listened to Marvin Gaye and Tammy Terrell singing Boo-Doo-Doom. I can't think of the name of it, but Your Precious Love. So that's a romantic song, but it has a spiritual message to it. So I did those kinds of things. And then I'm here by myself. So that's been difficult, but I've been able to connect with colleagues, faculty, and staff in ways, and we're looking at ways to support our own community, both in the college and externally in some of these same things. And doing those has been a support for me as well.
Thank you. Dr. Kapoor?
Well, so kind of at the end of each day, at the end of each week, our deputy CEO, Dr. Penson, would have a pep talk for the weekend. And he would say, we're in a marathon, not a sprint, but he would always say, you need to go home and do something for yourself this weekend. You've got to get some rest. And so he almost gave it as a command that we had to do that. And so when I listened and I did that and would get, you know, a Saturday where I could sleep a little bit more, I felt like a completely different person just being able to have a few hours of sleep. So that was one thing, is I realized how important it was to take the time to get some sleep. But I just to Randy's point, I really like to watch films with subtitles. So I love French films and Spanish films, and just anything that I can watch. I love to read the subtitles and listen to the language, because the languages are so beautiful. And so that would really pull me away, both my mind and visual and all of my senses toward that. And I'd spend a lot of time just kind of watching whatever I could find on BBC or Acorn or any of those channels.
Well, thank you. Dr. George?
Well, I have to admit, I probably could have done a little better job, because I've gained 25 pounds this year, but, which I don't think is that uncommon at the moment. But anyway, I think really humor has really seen us through so many times. You know, there have been nights at 11 o'clock when our group was still working and we were so exhausted we could barely see, and some of us, you know, had tears running down our face, but we're still working. That, you know, we could find the humor still in the darkest of time and the most stressful of time, and it just always broke the tension, and it always you know, let that was that release valve, and that was really important to us. We have a Teams thread that goes all the time in our command center, and we have silly memes, and we start the day with, you know, silly slogans and things, and it's bonded the group, and it lets us, you know, blow off some steam where we needed it. Sometimes just stepping back and breathing. We've had a number of times where I myself have gotten completely overwhelmed, or one of my staff have, you know, I could tell they were really getting there and getting completely overwhelmed, and just saying, step away from the computer and breathe for a moment, take a 5-minute walk, change your perspective, and it just would renew everything, you know, when you could just take that moment to breathe, maybe get out into nature, as Randy said. That's been really important for me personally, is to get into nature and touch base with something natural and soothing and uplifting has been really important.
Thank you. Dr. Wogas?
Thank you. A lot of what everyone said, but particularly here in central Pennsylvania, we had a pretty wonderful wintry season this past winter, and I love to get out. I have snowshoes. Getting out into a forest where it's quiet and you just hear the quiet. It's fantastic. So that was really helpful. And then I adopted the use of the Calm app for sleep stories.
Yeah.
Just, I think what April was saying, that rhythmic, and Randy was saying the same thing, the rhythmic piece of that, either the music or the stories of people reading to you or something, really was helpful. I mean, Andrea touched on the things that we can do to help our team be resilient, but personally, I think, you know, all senior leaders have trouble disengaging, right, from every day. And I knew, you know, if I sent emails overnight, they were going to get responded to, and I didn't want that to happen. So I had to really moderate that and make sure I wasn't causing stress of other people, because that inadvertently, right, caused stress on me. And so those things were very helpful for me. But so exercise, really, you know what, I found that I wasn't limiting, I kind of didn't have as much maybe alcohol or glass of wine as I may have had. I just didn't have time for it, I don't think. Plus I was tired. I'd rather go to sleep and catch a few hours of sleep rather than do some of that. So diet, exercise, and like Randy and April said, music and reading and some cool, I'm an Avengers fan, so some cool Avengers movies. I'll just watch, I could watch Thor over and over and over again. That's just the way it is. So I think that helped me. But like Andrea said, I could have done better. I'm sure I could have done better at this.
You know, we share something else then, because I love Avengers too. I have all 3 movies on my phone. So if I'm in flight and the Wi-Fi's not working, I'm looking at Captain America again, but it's okay, because I love Marvel Comics. All right, Dr. Nelson?
Well, I'd like to say that I was refined enough to watch movies with subtitles or to drink less, but so I grew up in northern Wisconsin, and my wife and I and my daughter, we have a cottage on a lake in the northern part of Wisconsin. So once we got through that initial push where I was here all day, every day, I spent most of my free time and every weekend up fishing, whether it was ice fishing through the winter, or now this weekend, the sport fishing season opens, so I'll be walleye fishing. But I think the most important part, though, was I made intentional time away and let my teams know I was doing that to set that example. So, and my ask of them was that they do the same. My boss and I have a pact as well that when we're not here, we're not here. He's in Florida right now, and he texted me this morning about an email that went out. So I immediately texted his wife and told her that Brian's in his email again. So he gave me some grief for doing that, but we've made that deal. So it's really important to disconnect, and it is not easy, as Dr. Wolgass said, for senior leaders to do that. But I have a good enough team that I know that if I'm not here, the place is not going to fall apart. I think the best message we can give them is that if I were to walk away, the place would still be going, and and they have that same mentality.
I can't even say how much I've heard that coming up through the ranks from my CNOs. I'm taking leave, and if you can't handle it, I'll be back. So I'm glad you said that, and I'm glad you all shared your resiliency methods. I do want to just say congratulations to Dr. Kapu on her. She's the president-elect of the of the American Association of Nurse Practitioners. So kudos to you. I'm sure everything that you've learned will be helpful in your new role. I do have one question in the chat box. So if each of you would entertain the question equally, I'm sure Marshall Jackson would be appreciative. So the question is, what is the morale of nursing staff directly related to utilizing nurses in a needed position? I firmly believe that nurses are most effective and efficient when practicing within their specific scope of care, i.e. just as doctors practice as they are trained. So I am going to try to cipher this question, and I'm assuming, and please, Marshall Jackson, please feel free to chime in some additional comments if I'm not getting it correctly. I know some of us, or not us, but those that were in the midst of COVID pandemic in hospitals may have had to work outside of their scope only because of now we're in a needs basis. So from a morale perspective, did you find more of your staff willing to support working outside of their skill sets in a safe skill set position? And and when I say safe, like not a med surg nurse in an ICU scope of service, but let's talk a little bit about and possibly address Marshall's question about nurses and their morale working outside of their scope.
If I may, Dr. Godluck, so Marshall, I will say you're absolutely correct. And I would agree with you that, nurses, physicians, anyone is the happiest and functioning the best when they are in those areas where they are most familiar and trained. 100% agree. We were in some very extraordinary circumstances, and our teams answered the call. We had areas, so for example, when our surgery department all but shut down, the surgery nurses wanted to, they wanted to help, they wanted to do something, they wanted to be part of what was going on. And so, we really tried to get them into areas where they had some degree of comfort. A lot of them had worked in other departments, et cetera. So, we would try to work around that. Our physician partners did the same thing. Our partner clinic here, I can't tell you, I mean, it was well over 100 physicians that went through emergency credentialing to be able to practice in our hospitals. And, from all different specialties, with the understanding that, we weren't going to ask them to go and we weren't going to ask a family practice provider to go into the OR or, ask a nurse, a med surg nurse to go take care of the ECMO patients in our COVID ICU. But we really, they were okay with it because they wanted to be part of, most importantly, they wanted to be part of that mission. And also, I think the thought of, the unknown of maybe being laid off if you were in surgery or a procedural area, that's frightening if you have a family to support. So they all pulled together. I couldn't have been more proud of the nurses here in that regard.
I would say the same thing at Vanderbilt. I totally agree, Marshall, that you're best where you're trained, you're educated, trained, and you're expert. But belonging and being needed is also important. And, because my work is in advanced practice, I reached out to APRNs over and over again to do new and different things. And they were there answered the call every single time, whether it was we need to start a hotline, whether it was we need to open a tent by tomorrow morning and I'm calling you nurse practitioner so-and-so because you were in the military and I know you know how to do it. Let's put it together. We've got like 2 hours. Let's go. Whether it was opening up ICUs, all of our ICUs are staffed 24/7 with nurse practitioners. Whether it was the vaccination clinics that we're doing now, both on campus and in the communities. Our liver transplant nurse has just taken a liking to being over the vaccination clinics, and she's very good at it. So over and over again, they have been so open to doing something kind of outside of their comfort zone because they know that they're needed. And we recognize that and they're thanked. And we really celebrate the fact that they did do something new and innovative and exciting and have something now to add to their whole portfolio of what they can do and what they have done in their career.
Well, thank you.
I would add something from an academic perspective. So one of the things that I have found, and I think our faculty have found as well, is so our folks have, many of them have stepped up to collaborate in partnership. And I think that one of the things we're seeing is a much stronger collaboration or cooperation between town and gown academic nursing and practice nursing to step up to the plate and really learn about each other. So learning what it is we're trying to do in education, but reconnecting with what nursing is really about in the provision of care. This morning I was at breakfast and I heard 3 women talking, and I said, are you all nurses? And they were, and the reason I knew it was because they were neonatal nurses, and they were talking about being able to start IVs in neonates, but not being able to do that with adults, but they were practicing with adults. I would say one thing that I think we have to, as leaders, really be concerned about, and that is that the suicide rate among nurses is climbing astronomically. And I think that I was one of 11 deans that called on the American Association of Colleges of Nursing for us to really proactive have programs to support our colleagues. And I think that's both on an individual level, but organizational level as well. When we see what our colleagues are going through and what they're willing to step up and do, I really feel the burden both within academia, but for our colleagues in practice. How can we support, make sure that they're protected, but support them in the work that they're doing and help them to do what we had just talked about, how we replenish ourselves. Because, you know, nurses will step up to the call. I just remember the thing that we hear from flight attendants: put your mask on first before you assist others. We really have to help our colleagues to put their mask on first and take care of themselves, because if they don't do that and we don't support them, we're going to lose them. So that's a burden that's on my heart as well.
Very good point. Thank you for bringing that up. Anyone else? All right, so it looks like we are at the top of the hour, and I really appreciate and enjoy this discussion. So thank you all for participating. Any other questions, please put them in the chat and we'll get back with you. And other than that, you guys have a blessed and safe evening. See you soon.
See you
Bye-bye.
guys. Thanks.
Thank you.
Bye-bye.